EM board bombs.
Welcome back to EM Board Bombs. It's great to be back. It's May. It's 2025. Sunny here in Tennessee. Is it sunny in Colorado?
It's always sunny here. It's great.
Always sunny. Well, welcome back, Dr. Wasiski-Kuhn. As you can hear her lovely voice, we're happy to have her. We got some awesome things to cover today. There is so much to talk about. First of all, two major milestones in Dr. Wasiski-Kuhn's life.
True.
One much more important than the other. Let's go in order of most important. Most important is that you have a puppy.
I do.
It is literally in her lap right now. It is the quietest dog in the world. If you're on the YouTubes or the socials, it is it is like the cutest thing ever.
He says hello.
And it's waving. It's now waving at me.
It's literally asleep in
What's
my
his name?
hands. His name is Caspian, after Prince Caspian of Narnia.
There we go. Prince Caspian.
And his
happy. Eyes are like all droopy and sleepy.
He's just passed out. He's happy to help you guys learn today.
Adorable. Utterly adorable. And he's like, okay, I'm going to go back to the lab.
Yep. And now he's immediately asleep again. It's the best.
Check us out on YouTube if you get a wonderful puppy clip there. Absolutely adorable. Congratulations. I guess less important, oral boards are done. Congratulations.
Yep. Finished that the other day. Nice to have that behind me.
Yes. Congratulations.
I told Blake no one prepared me for how much paper I'd have to shred.
Oh my God. All the paper that she is holding up right now shredded.
Yeah.
From all the notes and fury. I'm surprised you didn't do a fire pit of it all.
Oh, I'll do that tonight.
Good. Okay, good.
Definitely.
Congratulations. Well done being done. You know, I'm sure you are going to advocate for EM rapid bombs. People will say that's bias. But, who cares? Who cares?
No, it was great. It was a great preparation. I had to do it.
Awesome. No product placement there.
And, there are some EM board bombs episodes to help you prepare for your oral boards as well. So those people taking the test in the fall, you should definitely.
We got more of those coming down the pipe. We were getting really good feedback on the EM oral boards cases. We'll try to also cater exclusively a lot of those oral board cases coming down the pipe to our premium subscribers. So check it out. Remember this EM board bombs, 10-minute episode, 15-minute episodes or so. We tell you what you need to know as an emergency medicine clinician.
That's right.
And if you want to be a premium subscriber, check us out at EM Rapid Bombs. Pretty sick stuff. Marlena just used it all for her oral boards, and she's one of our top producers for it as well. I still listen to it also when I'm needing a refresher on a topic. I will still listen to it, hammer out a few episodes. I'm doing yard work or on a run. So
yeah, it's
pretty
great.
Awesome stuff. For 2 to 4 minutes per episode, we tell you a multiple choice question, what you need to know for the test, and just some coaching pearls. Why the answers are wrong, what's right, what's better for real life, what's better for the test, etc. Nothing like it on the planet. Pretty incredible stuff.
Mm-hmm.
Hey, let's dive into this question here. So picture this. You're halfway through your shift. You've already had 3 strokes. You've already had 2 STEMI rule-outs. One of them cardiology took, the other one they laughed. And then 1 psych patient who tried to bless the code card with holy water, which was sink water, in part urine. We're not sure. You finally sit down with your lukewarm coffee. It's 2 p.m. You still haven't finished your coffee. And bam, you get an overhead page to one of your rooms. And there's a 68-year-old male. He looks like he's ghosting death itself.
Mm-hmm.
He's pale, he's cold, but actually sweating. And he's barely mumbling, minimally responsive. His blood pressure is very low. And the nurse thinks that it reads about 74/40 or something in triage. His heart rate is in the hundreds. He's breathing, not dramatic enough for The Pit, if you've watched that TV show. I've gotten so many comments from patients, by the way, about that. So funny. They're like, is this what it's like? Temperature is 37 Celsius, and oxygenation is about 98% on room air. SpO2 is 98% on 2 liters, and his lactate is 7. You're handed an EKG. It shows some sinus rhythm, non-specific ST segment changes, and then you do this bedside ultrasound. So good on you. Shows some global hypokinesis of the left ventricle. No pericardial effusion. Otherwise, nothing else really pops up. His trope is still pending. He already received 1 liter, normal saline, 0 improvement in anything. What is your next step? Choice A is start norepinephrine infusion. Choice B is administer IV hydrocortisone 100 milligrams. Choice C is begin dobutamine infusion. Choice D is an emergency CT chest to rule out a PE. Choice E, administer another liter of normal saline. Why not?
The right answer here is A, start the norepinephrine infusion.
Very good, very good. Perfect work.
Oh, I see that sip of coffee you just had there.
Yes, it's actually tea, black tea.
Oh, black tea.
Yes, I have my pinky out too.
Oh,
my pinky is out.
You
yes.
Traveling to the country of England recently?
I thought I'd mix it up a little bit today, some tea. Well, it's because also we should have a theme here. So I was thinking the rest of this question we need to do British measurements, but then I realized that British measurements are almost worse than American measurements. They even do more of a hodgepodge, whatever we do. We do like a mix of pounds, Fahrenheit, and the metric system, but they do pints, they do kilometers, they do furlongs and fortnights.
Imagine resuscitating your patient in like pints per stone.
Oh my God. Yeah. Yeah, that's what I'm saying. And they do it in an accent that it's difficult to follow. So then they could probably say the same thing about our crazy accents over here. So, hey, for this differentiated patient here, hypotension is clearly the main problem here. And there's a lot of other choices about doing certain interventions. Some of them involve doing further diagnostics like CT, but you're not going to be able to do that. One, on the oral boards, you'll flunk if you send an unstable patient to CT. Yeah. Two, in real life, it's just a little sketchy. And so forget whatever, weakness, dizzy, ultramental status that the triage put in the text box. When you have a patient with low blood pressure, you should go into an automatic functioning immediate reaction mode. And it's the, what's failing here? Is it a heart issue? Is it a tank issue? Is it a pipe issue? And people do that plumbing reference all the time. But really the main thing is first 5 minutes, I want you to go over the immediate reactions that you would do in this case.
Yeah, exactly. Like, what do you see when you walk in the room?
Yes, it's perfect. See, hear, smell.
What are you smelling?
Yeah.
Your ABCDE. Is your airway patent? Is the patient breathing normally? What's the map if you can get one? What are the signs of perfusion? What's the patient's mental status? Can you check their cap refill? Like, honestly, I know people talk about cap refill a lot in peds, but I check cap refill in all my adult patients. It's kind of like, I touch their feet and see if their feet are hot, cold, clammy. Do they have a DP pulse that I can feel? And then on their hands, I'll do like a quick cap refill, and you get a ton of information just from that 5 seconds. Then for disability, your rapid neuro exam, is this an obvious stroke, or is this just like a generalized like weakness and depression of mental status? Mm-hmm. Just a shock. And then exposing your patient, looking for trauma. Do they have Fournier's gangrene that you wouldn't see otherwise if they weren't exposed, mm-hmm. or some kind of other rash that's toxic and obvious? Or do they have a massive GI bleed that you wouldn't notice if you didn't expose them? Something like that.
Totally. And my favorite, turning the patient over on their back and they have 4 fentanyl patches on.
Yeah, that too.
Happened once in my career so far, but yes, always fully exposing your patients. It's not just trauma patients. It is your sick medical hypotensive patient. You are fully exposing them. Yeah, and it's almost like this first 5 minutes is an immediate reaction. Like, you're not really thinking in this in terms of just like, I'm just looking around and I'm reacting to this blood pressure. And that involves, the 2 large bore IVs that hopefully the nurses are getting, hooking up to the monitor, getting the pulse ox, putting them on oxygen if they need it immediately, titrating up on that oxygen if they need a lot more depending on the work of breathing.
Right.
But you're not delaying any access or oxygenation. You're doing all that at once. There's going to be a bunch of labs you send. We're not going to go over that. It doesn't matter. You're always going to send like a huge amount of labs on these sick patients. So like, that's not the point of this podcast. You're going to send a boatload of things. You're probably going to send blood cultures. You're probably going to send CBC, CMP, type and cross if needed. All this stuff that like, again, is not needed. You're going to order a chest x-ray. They're not going to be there right away. You're going to order an EKG. Again, not going to be there right away, probably. You're reacting to this blood pressure. If your nurses can't place an IV, guess what you're about to do?
Place IV.
Exactly. You're going to place IV yourself if you have an ultrasound. That's great. If you're not good at that, then you're placing an IO. If you either get an IO or don't get an IO, or you got an IO and you need more access, then you're going to put a central line, a cordis or central line somewhere that you are comfortable putting one, either IJ or femoral or subclavian. That's awesome. And then what is probably the number one universal reaction to do to anyone with low blood pressure that is pretty much harmless? Like, you're never going to get in trouble for doing this. It's always the right answer.
Just give him a liter.
Give him a liter of crystalloid. Exactly.
Which, like,
this is never the wrong answer.
Your nurses probably already started without even asking you.
Exactly. Or EMS or somebody did. Yeah. What's funny is whenever I have students or residents with me and I'm like, have a hypotension patient like this and we can talk for a second though while everything's kind of happening. I'm like, so what do you want to do? And they look at me like it's like is he tricking me? Is this a trick? Is this, does he want me to say a liter of fluid? And I'm like, yeah, it's a liter of fluid. Just like give a liter of fluid. Like no one knows what's going on yet. And no one's going to fault you for doing 1 liter of fluid. Especially when the vast majority of shock in this country is due to either some form of distributive or hypovolemic shock. And if it's both of those two, then it's a good bet a liter of fluid is not going to do any harm.
Yeah.
In that case, when you have no idea what's going on with the patient.
Yeah.
You're in a non-trauma patient, of course.
Right. This is like the patient you don't know what's going on with.
Exactly.
If this is the patient that comes in and they're on a milrinone pump and their milrinone pump's not working anymore, maybe like don't give them a liter of fluid, but hopefully you know what's going on with that patient. It's pretty obvious.
Yeah. Or they're like hypotensive and then they have like you're cutting out their clothes and you see they have like a embedded pump for like pulmonary hypertension. You're like, oh no.
Yeah, right.
Oh no. Oh no. Hey, we need to pause there and talk about rapid bombs again.
Oh my gosh. Yeah. All of those things.
Just two plugs. I
mean, everything we just talked about has their own episode on rapid bombs. Literally,
in-depth
almost every sentence that we've said in this episode has had its own rapid bombs.
It is for sure. Over 500 episodes now on EM rapid bombs. Check us out. Again, 2 to 4 minute podcast episodes. Mm-hmm. It's a question bank podcast. It is the only question bank podcast in medicine. So talk about that quick, rapid learning where you're just getting that small dose of learning a day. So it's not overwhelming. You're not going to zone out. You're going to get a quick, high-yield summary of a multiple choice question and a topic. Yeah. And that'll set you straight. Yeah. And you can also just cram a bunch of episodes together before your test. It's awesome.
Yeah, you can. The question is short. It's not like a big, long stem.
Yeah.
It's 1 or 2 sentences, very focused. And then a couple learning points about that focused question, specifically tailored to the things that you need to know for that question, how the test is going to ask you about them, but also in real life, what you would need to know to help a patient with that specific problem.
Totally. So where do you go to check it out? Sign up?
Yeah, you can just go to emboardbombs.com or you can just Google
main website.
EM Rapid Bombs.
Totally. One of the two. And it's a one-click sign up. Seriously. If you go to emboardbombs.com, we have our 2 plan options. We have a trial option and a main option. Just sign up. And I'm not kidding you. It's like 2 clicks and you're subscribed. And it downloads to your podcast automatically. It's pretty sick. So check it out.
Yep.
All right. So the first 5 minutes are over. You've reacted appropriately. You have maybe not narrowed down anything at all on what's going on with this patient. That's fine. All you're doing is reacting. You're getting your baseline vitals. You got access. And you have given a liter, most likely. What is your next step? Like the immediate thing. Again, the chest x-ray is coming, but let's say the portable is not available yet. It hasn't come by yet.
Yeah, and we mentioned this in the question stem. The rush exam.
Yes, totally.
Rapid ultrasound and shock. It's great. If you're not doing this already, you definitely should be. There's plenty of learning resources out there to look how to do this. You can do it with 1 probe. You look at the heart. You're looking, for a general squeeze. Is it normal? Is it terrible? And then are there any signs of tamponade, like a huge effusion? Do you see any like severe RV strain? Do you have like a big D sign? Is your RV just like blown out? Something like that. These are quick yes, no questions. You're not doing any huge calculations here. It's not like a advanced echo. And then you look at your IVC. And again, like this is just a quick yes, no.
Basic stuff. No measurements.
Yeah, no measurements.
Yeah.
Is it totally flat and collapsible or is it like plethoric, not moving at all? So is this completely obstructive or is the patient really hypovolemic? And then you're doing the fast. Is there any free fluid? Are you worried about a ruptured AAA? Are you worried about some kind of like a splenic lac? Is this a missed trauma or a sporadic intraperitoneal bleeding? So again, like a tank problem. And then looking at the lungs, do you have a pneumothorax that's contributing to some kind of obstructive shock, or do you have B lines that would be indicative of a heart failure, or even like ARDS? And then that can help you split patients into a hypovolemic state, cardiogenic shock, distributive, obstructive. There you go.
Totally. That's an awesome summary. So most emergency physicians, especially if you've graduated within the past like 5 years, even like 10 years, know how to do a fast exam. So there's that. The echo really, just to even simplify things more for anyone listening to this and you're like, gosh, I really don't feel comfortable doing echoes. I never really got that down in residency. I'm in private practice. I don't think about that. Then just get a subtyphoid. That's literally part of the fast exam. And most of the time, I really do feel like the subxiphoid, in my opinion, is like the poor man's apical 4. You have a good general view, at least of the two ventricles, minimum, the right and left ventricles. And you have those questions that you just asked right there. Is there tamponade? The easiest question ever on an echo. What's the general EF? And really the more nuanced question, if you just have to see a bunch of normal echoes, is the RV really big? Is the right ventricle really dilated? Who owns the septum, as I like to ask residents? Is the septum pushing into the right ventricle, which is normal, or is it pushing really hard into the left ventricle? Again, all concerning things. But that is all just part of your FAST exam. And the rest is like extra stuff, which is great. But just the basics are doing a FAST exam at least, which includes a subxiphoid view, or an EFAST, which includes your lung sliding.
Yep.
And yeah, that splits these patients into what 4 categories? We've covered podcasts on this before. We're not trying to go in detail here, but just an overview of your sick patient.
Yeah, so you have hypovolemic shock and cardiogenic shock, obstructive shock, distributive shock. And you have some early fixes for each of these things. So in hypovolemic shock, you have IV fluids, which you've already started. Great. Good on you. And then source control. So like, is this a bleeding problem? Are these GI losses? And you can address them appropriately once you've identified that. Cardiogenic shock. So start your pressors, avoid overhydration, and add inotropes if you need to. Obstructive shock. So is this tamponade? Do you need to do some kind of tap? Do you need to needle? Do you need to lyse a PE or do a thoracostomy? And then last, distributive shock. So is this something where you need to start the antibiotics because you've already collected the cultures, because you did that when you stuck the patient, and then start some pressors? And remember that norepinephrine is the first line pressor for most and pretty much all undifferentiated cases. Again, we have an EM rapid bombs episode all about this.
Totally. We totally go into detail on pressors and inotropes. It's pretty awesome.
But that's a safe start for a pressor in cases of distributive and cardiogenic shock.
Excellent. Yeah, what are the common pitfalls here? So I would say the number one most common pitfall I see with residents and students is delaying pressors, waiting, quote, for that fluid trial to finish. Don't do that. If you got a sick patient, you've given a liter, no response, like ramp up quickly, you can ramp down later. I've had so many cases where we've ramped up early with that norepinephrine. We weren't sure if it was distributive shock or hypovolemic, but we got like 2 liters in, absolutely zero change. And it's by then you're like, okay, I'm not even waiting for this 30 cc per kg thing to finish. I'm starting norepinephrine. And the data is unclear on that on our septic shock patients, but it doesn't matter. In real life, if you're not moving the needle at all on a sick patient, no one's going to fault you for ramping up early. And remember, as Marlena just said, norepinephrine is that first-line pressor for pretty much everything. You're never going to go wrong starting norepinephrine on a hypotensive patient, especially if you have no idea what's going on.
And there's plenty of evidence that you do not need central access to start your norepinephrine.
Totally. Absolutely. Yeah. I have not ever waited on starting norepinephrine for central access. I've always started a peripheral line or an IO. Another pitfall is anchoring too fast on sepsis before ruling out other things like tamponade or a PE or hemorrhage. Don't always just assume it's separate sepsis. Unfortunately, we see so much sepsis that it is tunnel visioned us into thinking a little old lady with hypotension is sepsis. And there's probably a good bet that it is sepsis. But you always have to do your due diligence, especially if they're not responding after you've given that 30 cc's per kg, after you've given those antibiotics, etc. Not using ultrasound early is another pitfall. Again, this just comes down to just repetition. There's really no excuse for it now. Almost every emergency department in at least the United States has some form of an ultrasound. And please do not email or call me and say, my ED doesn't have an ultrasound. Then I'm really sorry you don't. You need to work on that. You need to probably get one.
Yeah.
But seriously, though, especially with how much, portable ultrasounds cost now. They're so cheap.
Your boards expect you to do that too.
Yes,
so.
Absolutely. It's standard of care now. Standard of care. And the last pitfall is missing any type of occult bleeding in elderly patients on blood thinners. Such a common issue now. So many people are on blood thinners. And again, little old lady that comes in and you think, oh, it's sepsis. But you never turn their back over and look that they had a bunch of fentanyl patches on them. Or they, from their nursing home, they forgot to take the old ones off. Or they, Marlena loves that one. Or they have bruising on their back and you didn't, think about a retroperitoneal hemorrhage, didn't scan their belly. These are common things you got to think about here, okay? Why don't you go through why the other answer choices are wrong, and then we'll summarize here.
Yeah. So answer choice B was hydrocortisone. So it's not wrong in refractory shock, but that's not where this patient was yet. This patient hasn't gotten adequate vasopressors or really addressed the root cause of their issue. So maybe the right answer down the line, but definitely not at this point. Choice C was dobutamine. So dobutamine's an inotrope, so that increases cardiac output, but it also causes vasodilation. So you definitely don't want to start that before you've started a pressor, because the balance between the increased output and the peripheral vasodilation can lead to that like classic teaching that a third of patients are going to drop their blood pressure, but a third have no change, a third have increased. You can't predict that. So you don't want to start it and end up with that patient who drops their blood pressure when they're already hypotensive. So add your vasopressor first, then add the inotrope when you already have a stable MAP. So norepinephrine and then dobutamine if you need it, if that's your problem. D was CT chest. Like we said before, this patient is too unstable. Don't take them to CT scanner right now. You don't have any signs of PE on POCUS. You don't have a reason to think it's a PE. This adds delay without changing the initial treatment. And honestly, if you got down the road where the patient really had convincing signs for PE and they were still too unstable to do anything, you'd be thinking about like giving thrombolytics versus taking them to CT if they were, circling the drain.
Right.
And then the last answer was just more fluids. So remember, the patient's IVC and lungs suggested that he was already volume appropriate or even borderline dry. And so more fluid might harm this patient. You don't have a reason to think that he needs to just be slammed with more fluids.
All right, let's do a short here for the socials here. Marlena, I'm going to put you on the spot. Let's list those common pitfalls again. I feel like that's the most high yield here. What are the common pitfalls in a hypotensive patient within the first 5 minutes? We got 4 common pitfalls. Why don't you tell our listeners on the socials here, what are the 4 common pitfalls?
Yeah, common pitfalls to avoid in your hypotensive patient in the first 5 minutes. The first one,
boop,
delaying pressors, waiting for your fluid trial to finish. The second one is anchoring too fast on sepsis before you've ruled out other things like hemorrhage or tamponade. The third one is not using your ultrasound. Use your ultrasound early. It's your best friend. And the last one is missing occult bleeding in the old patient on blood thinners. That's so many of them. You can't miss it.
Sweet. All right. Check us out, emboardbombs.com. Find us there for a subscription to Rapid Bombs. Check out other content. We've got study guides. We got an airway module. We've got so many things to keep you edumacated. Check us out. And don't forget the puppy. Hello to Caspian. Welcome to the EM Board Bombs family. You can check us out at YouTube to take a look at the puppy. What a cute little animal. All right, we'll see you all next time. Thank you.
Bye.